right, so we'll go ahead and get started. Thank you everyone for joining us today. My name is Dr. Olutayo Sagunro, and I am a general and trauma surgeon. And I founded an online platform called The Do Influence, where we hope to educate, empower, and influence students of all ages to reach their fullest potentials. And one of the ways that I wanted to make sure that we do that is through healthcare advocacy and healthcare education. So I have some of my esteemed colleagues and friends today that have all volunteered their time to talk to you all about men's health. Before we get started, though, I would love to introduce Mr. Renat Kager. We today have the honor of participating in this event with a wonderful sponsor. Our sponsor today is I'm going to make sure I say this right, the Omicron Sigma Chapter of the Phi Beta Sigma fraternity. They have been wonderful with us and really wanted us to get the word out to their fraternity and invite their members to join us today, because men's health is public health. It's everyone's health. It's important. So, Mr. Kager, would you like to give a few opening words today?
Sure. Thank you, Doctor. So, like you said, my name is Renard Cager. I'm representing the Omicron Sigma Chapter of Phi Beta Sigma Fraternity Incorporated. We were founded in 1914 at Howard University in Washington, D.C. area. And we are founded on the principles of brotherhood, scholarship, and service. And we have three main programs of education: bigger and better business, and social action. And this falls directly under our social action purview. So it was really great to be, part of this, because taking control of our own health will strengthen ourselves, strengthens our families, strengthens our communities, strengthens the society as a whole. So thank you very much. Back to you, Doctor.
Thank you so much, Mr. Kager, for those words. I would like today to introduce our panelists. We are very honored today to have, again, three of my esteemed colleagues. First, I will begin with Mr. Obeng. Dr. Obeng. Dr. Obeng is an internal medicine physician based in Virginia. He completed his Bachelor of Science and Master of Public Health degrees at the Ohio State University in Columbus, Ohio, and he went on to medical school at OUH-COM. He completed his internal medicine residency at St. Joseph Health Center in Warren, Ohio. He currently works as a staff physician for the Veterans Administration Medical Center in Hampton, Virginia, and he previously worked at Bon Secours Health System as well as men's wellness centers. We're really pleased to have him today on our panel. Next, I'll introduce a close friend of mine, Dr. Benjamin Brang. He is a board-certified physician in both family and sports medicine. He is not only a program director in a family medicine residency program in Ohio, but he's also the director of osteopathic education at Dublin Methodist Family Medicine Program in Dublin. In addition to his role as the program director, he also works as the head team physician for Grove City Central Crossing High School. He is also the medical director for the Ohio Health Capital City Half and Quarter Marathon and for the Emerald City Half and Quarter Marathon. He has been a great friend, colleague, and really advocate for his patients, for his residents, and really for medical students. So we're really, really grateful to have him here today. Next, I have Dr. Spencer Nadolsky. Dr. Spencer Nadolsky is also a friend that goes back several years to me. He is a board-certified obesity specialist. He's a lipidologist and a family physician who has helped thousands of patients over the past 9 years lose weight and keep it off. In combination with RP coaches, he uses lifestyle as medicine to treat and prevent chronic diseases via telemedicine. He has an undergraduate degree in exercise sports science from UNC Chapel Hill, where he also wrestled heavyweight and was ranked in the top 3 at one point in the nation. So I guess don't mess with him. Dr. Nadolsky is also very big on social media. He does have social media platforms for which he helps patients all over the world. So I'm sure he'll tell us a little bit more about that during the talk as well. So I would just like to welcome my 3 panelists today. And if you guys want to give them a silent round of applause or anything like that, feel free to do so. Again, welcome to our men's health panel today, and I will get started with Dr. Obeng. We will start with heart disease, prostate health, and erectile dysfunction, talk about male reproductive health. Then we'll move on to musculoskeletal injury and prevention and management with Dr. Bring. And then we will move on to fat loss and cardiometabolic health with Dr. Nadolsky. And then we will have an open answer and question and answer session at the end. All right, take it away, Dr. Obeng.
Great. Thank you so much, Dr. Segundo. I really appreciate you having me on this panel. I appreciate all the panelists. Thank you so much, Dr. Nadolsky, Dr. Bring, for having me as well. So I just want to kind of give a broad overview. I'm an internist, so and kind of along the same lines, since we're all panelists, we all have more of a foundation in primary care. So I kind of took it from that approach in terms of dealing with men's health. So one of the main things we have to deal with, especially with in terms of men's health, is the fact that heart disease is one of the leading causes of death. Typically, men who are in their 50s to their 70s are more likely to die of heart disease compared to their female counterparts. It's one of the top causes of death that kill men greater than women. And in terms of some of the causes and the risk factors associated with heart disease, a lot of them are probably really well known to the public. One of the main things is high blood pressure. Typically, we know that it's a silent killer because you don't know when your pressure is too high unless you get it checked at the doctor's office or unless you check it yourself. And in terms of the ranges that we look at, I just put in there, as you can see in the presentation, what we consider normal. Now, the guidelines have changed a little bit over the years in terms of the different societies. American College of Cardiology has adjusted it just a little bit. Normal is considered less than 120 over 80, and then pre-hypertension is considered between 120 and 139, and hypertension, stage 1 hypertension, is greater than 140. It's shifted a little bit. They've gotten a little bit more strict with the categories, but it is something that affects us men tremendously. As you can see in the PowerPoint, estimated about 67 million Americans have high blood pressure too. And it's one of those things that it is just very treatable. So when you address that, you address a lot of issues when it comes to preventing cardiovascular disease down the line. And in terms of the general heart disease, the other risk factors on top of blood pressure, which we already kind of discussed, was obesity and overweight. And I know Dr. Nadolsky probably be discussing that as well. And diabetes. Diabetes, I can't tell you how many patients I have that are diabetic, especially here in Virginia. I have a lot. So, and that's one of the main risk factors. It's a risk factor for cardiovascular disease. Basically, when you're diabetic, it affects your blood vessels, and that can lead to things like heart attacks and strokes down the line. So it's one of the things that we look for in terms of people developing heart disease down the line. Other risk factors, high salt diet, that more falls in line with the high blood pressure piece. And that's one of the things that we, as doctors, tend to advise our patients in terms of watching their salt intake. And of course, smoking as well. That's a big no-no. With a lot of my patients, that's one of the top things I tell them is to quit smoking. And we have options in terms of helping people quit. But the main thing is the patient has to be ready to quit. A lot of times when people try and quit on, almost forcibly, a lot of times they won't be successful. They have to kind of make their mind up that they want to quit smoking. So those are some of the big risk factors when it comes to heart disease. Okay, and this slide here, basically, you can see the man and the woman at the starting blocks there. Just basically, it's a comparison graph, just so you can see in terms of life expectancy between different genders and different ethnicities as well. You can see us as men, our life expectancies are at least about 5 years less than women, and it goes across all demographics, essentially. So it's kind of a warning signal to us in terms of what we need to be doing in terms of our lifestyle, in terms of the things that we do. As men, we tend to be less likely to go to the doctor, which, let's be honest, that's typically how it is. When I used to work at my old job at Bon Secours, I'd say a majority of my patients were female, and the men that came usually had to get prompted by their wives or girlfriends or significant others to come to the doctor to get checked out. So that's another thing too. We tend not to want to be checked out. We're afraid we're going to find out something wrong. It's kind of like going to uh, the mechanic. You know, you go to the mechanic from one thing, and then you find out you have like 50 other things wrong with the car. So it's a lot of men are turned off. They don't want to go and get checked out and get evaluated. But it's definitely one of those things, as we can see here, is important that we at least get our annual physical as men. All right. And the other thing I wanted to touch on too was prostate health. I'm just going to give a general overview. I'm by no means a urologist, but just to give a general overview in terms of prostate health, because it is something that affects us as men too. One of the things, well, first off, I'll kind of back up here. That picture right there, as you can see to your left, is basically the anatomy of the male reproductive system. So you see the bladder on top, you see the prostate underneath, on the urethra, and so forth. Typically, what happens as you get older, the prostate tends to get enlarged. And typical signs that you'll see is that you'll see problems with urination, where you feel like you have to urinate a lot, or you feel like once you pee, you're not able to get enough urine out, or you start urinating and it's a struggle to get out. That's typically a sign. Those are, for the most part, typical signs of an enlargement of the prostate. In terms of risk factors for people who tend to have enlarged prostate, typically it's men who are older than 50 on average, and also men who have a family history in terms of like prostate disease. And I'll back up and I'll kind of differentiate between BPH and prostate cancer. African American men, as well as people who eat a high fat, low fiber diet, and people who have a history of a prostatitis. So prostatitis, what is that? That's basically inflammation of the prostate. That's usually due to a bacterial infection. Now, a lot of times you have patients who might have an enlarged prostate. You evaluate them, and then you essentially, what we do is we treat the symptoms in terms of the enlarged prostate. Now, when it comes to actual prostate cancer, there's a couple of things that we do. We look at those risk factors, which I mentioned: their age, their family history, their ethnic background, their lifestyle change. I'm sorry, their lifestyle, and then that typically guides us is to following up what the likelihood of them having prostate cancer. So as you can see there at the bottom few bullet points, that a couple of things we look at are a blood test. So the first thing we look at is something called a PSA. Now, different doctors use a PSA in different ways. I would say it's one of those things that the patient and the doctor have to talk about initially. We always look at this versus benefit of testing for that, because other things can throw that number off. It's not 100% guarantee that the PSA is high, then this person has prostate cancer. It's something that is more of an indicator. And then moving forward, you look at other factors. For example, if patients had recent instrumentation, like they've been riding their bike, or they had, for example, maybe like a colon procedure or something like that, that can artificially make that PSA go up. So that's something the doctor would have to be aware of, talk to the patient about. And also, if they've had intercourse recently, that number can be artificially high. So it's one of those things that's more of a screening test. And then once you go there and you get a good history of the patient, then you can move forward to further investigate the possible causes. The other thing they do is the finger wave test. I'm sure a lot of you guys have heard that when it comes to the assessment and diagnosis of prostate cancer. That basically is where they feel for the size and the size of the prostate, see if there's any lumps or bumps in there. For the most part, as doctors, what we're looking for is to see if we feel anything that feels irregular. And then at that point, it would lead us to say, okay, as I'll speak as an internist, after I do that exam, I'd say, okay, it's time maybe for you to see a urologist, and they would actually go and actually take a sample of the prostate to look for any signs of cancer in there. And that's a biopsy that they would do. That's the typical steps that we take in terms of assessing for prostate cancer. So the main thing is definitely, especially if you're over 50 or if you have a family history, getting evaluated for that, because that's very important. That's something that's very treatable if we catch it early. All right.
I'm sorry for
Thank you.
joining. I'm sorry for joining late. Can we ask questions now, or we wait to the end?
I think you're muted.
We wait to the end, if I believe. Yeah, that's correct. You're muted, Doctor.
Yeah, I'm sorry, you were muted there.
Yeah.
I'm so sorry. Yes, I said we're waiting till the end. Mr. Kager jumped in for me. Thank you. We're waiting till the end, but if there's something that you really want to ask and you don't want to forget, feel free to write it to the Duo Influence in the chat, and I will make sure that we ask it and that we don't forget to answer it.
All right. And in terms of reproductive health, as you can see here, it's one of those things that is important in terms of looking at both sides, because a lot of times when we're coming to people having children, a lot of times what they'll do is we'll look at both the male and the female side. A lot of times it could be due to the man's fertility, whether it be he has a low sperm count. Those types of things tend to affect the fertility. So when it comes to things like that, conception on the man's part, a lot of times what a fertility specialist will do, they'll do a semen analysis to look for how healthy the sperm are, if they're motile. So those are things to think of whenever you're thinking about reproductive health, whenever you're thinking about trying to have children. Those are some factors that we as doctors look at and something to keep in mind if you're trying to have children as well. All right. Thank you. All right. And last, I think, no, it's not the last thing, but basically erectile dysfunction. And that seems to be a hot topic these days, right? I'm sure we've been inundated. I think like we've had 20 plus years, and the other docs on the panel can correct me on it, but I think we've had 20 plus years of, medication, Viagra, the blue pill. Everybody is very familiar with that. So a lot of times we want to see what the cause is. A lot of my patients, I'll speak from personal experience. A lot of them feel like, oh, doc, I've been having some issues with erectile dysfunction, and just go ahead and give me some Viagra, give me some, Cialis, Levitra. A lot of times you have to look at the causes. There could be other reasons why people are having ED issues. And a lot of times it could be a psychological cause too. It's not the only cause, but it can be one of many causes. So as a physician, what we typically like to do is make sure that we're addressing those causes, trying to dig deep into the patient's history to see what else could be causing their ED symptoms. A lot of times when you get to the root cause, whether it be depression or diabetes or blood pressure, once you treat that, typically that will help resolve the ED issues that the patient is having. And so as you can see here in the slide, there are multiple causes of erectile dysfunction. Part of it is psychological, medication-induced, of course, various disease states or physiological reasons that people have erectile dysfunction. And as I mentioned earlier, a lot of times you'll see guys who have had psychological issues too, depression, and even some of the antidepressants can cause that too. A lot of the SSRIs or serotonin reuptake inhibitors are very classic for giving men ED. So we always look at those factors as to why people are having, especially men, are having ED symptoms. And as I mentioned earlier, blood pressure is a very common thing. A lot of times when you get the blood pressure under good control, you tend to help resolve their ED symptoms. And also diabetes as well. Diabetes is a common thing. Heart disease, coronary artery disease. We talked about that earlier in our presentation. Thyroid, that's the other thing too. If people have low thyroid, that can be another reason why people are having ED symptoms. And then hypogonadism, or basically like low testosterone. I'll talk a little bit about that on the following slide. And as I mentioned before, in terms of medications, some of the medications are like antidepressants, which I mentioned earlier, a lot of the SSRIs, pain medications. This is something I learned later on in my training as a resident. Things like Percocet, a lot of the opioid medications, those can actually cause ED symptoms. They can also affect your testosterone too. That's another thing to be aware of. Anti-seizure medications as well. Certain BPH medications like finasteride sometimes can do that. And some of the anti-anxiety medications, like benzodiazepines, those are more for when people are having like an acute or like a sudden onset anxiety attack. Those types of medications can also do it too. And of course, blood pressure medications. I would say one of the things that this is my personal practice for a lot of my gentlemen who have blood pressure issues. I try to avoid those beta blockers, and really they're not the best for blood pressure unless the person has something else, like they've had a heart attack or stroke or some other cardiovascular issue. But if they just have pure blood pressure issues, and a lot of docs do this, that's not usually the first go-to medication unless some other extenuating circumstances going on. So, so those blood pressure medications, excuse me, especially the beta blockers, tend to do that, but other ones can too. But beta blockers are notorious. And of course, in terms of dealing with ED, lifestyle modifications, of course, especially if it's due to things like blood pressure, obesity, that type of thing. Therapy, psychotherapy is also an option as well. In terms of your patients who are dealing with mental health struggles, in terms of your ED, and of course, medications like Cialis, Viagra, those are typically prescribed. And then the intracavernosal injections like alprostadil, those are more of a last-ditch effort for guys who have severe erectile dysfunction. Alrighty. And then the other thing I wanted to touch on was testosterone therapy. Typically, testosterone is, as you guys know, is a thing that basically makes us men in terms of our physical attributes. It's important in terms of improving our muscle mass, libido, as well as in terms of facial hair, and also energy levels, and to some extent mood too. And typically, when men have low testosterone, some of the symptoms are they have like a low sex drive, low energy. They feel tired all the time. They have some muscle mass issues where they're feel a little bit weaker than they used to. They tend to have a little less facial hair. And then rarely you'll have some issues where they actually have some testicular atrophy or genital atrophy. And when we look at that in terms of screening for low testosterone, a lot of times I would say the first thing we would look at is a history. That's always important. You have to see the patient's background. Do they have any congenital problems, or do they have any issues growing up? Look at also their testosterone levels. You can also do semen analysis as well, and other imaging studies. But typically, you'll start off with the patient's history, and then also check their levels, and also check other factors as well. But testosterone, you also want testosterone tests. At least you want to get 2 different ones. You don't want just one, because it can vary depending on the time you check it. And then in terms of treatment, there are a number of treatments available. As you can see here on this PowerPoint, a lot of times we as doctors prescribe injectable testosterone. There's also topical testosterone. With the topicals, a lot of times those are easier because the person can just administer it directly themselves. The main thing with those is you have to be very careful, because you have to let it sit for a little while. You don't want it to rub on your partner or on your children, because they can also absorb it as well on their skin. And then also too, it's just basically, it can be a little bit of a hassle in terms of day-to-day activity. Now with injectables, those tend to be for a patient who can give themselves the testosterone shot. It tends to be an effective route of treatment for them. But the only downside is you just have to stick yourself. That's the only main problem with that one, I would say. Then there are other options too in terms of pellet therapy. That therapy tends to be a little bit more you have to actually put it subcutaneously or into the skin. That one tends to be more longer acting, in the sense that people who have the pellet therapy, they usually keep them in for a few months, whereas the injectables and the creams, typically that can be adjusted every few weeks if need be. So that would be, I would say, the main difference between those. And then there's also like the nasal version, which I personally have not used that, but it's also an option there. And then the mucosal version, basically where you put one in the gum area. All right, and then these are just basically the pictures of the different versions. As you can see there on the top left is the injectable version, and then I put the logo of one of the nasal gel, and then also the topical, the androgel on the bottom right side. Now, in terms of cautions, a lot of times it goes again back to the patient's history. You have issues with their red blood cells getting high, basically blood getting thicker too. And then also risk of cardiovascular disease. And you see that primarily in men who already have risk factors, are a little bit older. They've actually done studies to look at that, and they noticed that it was more so in elderly men that had more of that cardiovascular risk than younger men. Also risk of increased acne. And then there have been studies look at risk of prostate cancer associated with that, but those tend to be people who already have risk factors for it. So you want to monitor people's prostate number, which we talked about earlier on that too.
Yeah, well, Dr. Obeng, thanks so much. What tons of great information there. I just want to say it's such an honor for me to be on this panel with this esteemed group. Dr. Segunro she was one of the smartest people in med school, and one of my best friends from med school. So it's really cool to be able to reconnect like this. So thanks for having me. So today, so my background is in both family and sports medicine. So after I finished my family medicine residency, I did an extra year of training in sports medicine. And one thing I really just kind of wanted to touch on today is just some things, some tips and tricks that you can do, kind of as you go on and as you age. Unfortunately, right now with COVID, there's been a lot of my patients, especially men, have been a lot more sedentary than usual. Spending more time sitting at home, spending more time drinking alcohol, not exercising as much, spending more time binge watching TV, your favorite Netflix shows. And so it's super, super important when we talk about injury prevention and management. A lot of this ties in with Dr. Obeng's presentation too. As a family doctor, I always say first and foremost, I am so focused on preventative care. So how can we not only prevent injuries, but also some of those chronic diseases that Dr. Obeng had mentioned there too, such as high blood pressure and diabetes. So for the musculoskeletal system, I'm a big fan of resistance training. I know Dr. Nadolsky has some great content out there too for some weightlifting. I'm a huge fan of resistance training. There is a ton of really great data out there for weightlifting, resistance bands. And one of my favorite things I try to tell my patients to do is after you eat a meal is go take a walk. I think, in our society, it tends to, our habits tend to want us to do is eat a big meal, and then go lay down or go sit down. So that's one of my favorite things to do to tell patients is make sure you're staying active, go out and walk. And unfortunately, too, as Americans, I think we kind of eat too much. I know Dr. Nadolsky will talk about some of this too. So kind of managing those portion sizes is very important. So before I got into the musculoskeletal stuff, I did want to give some of the family medicine stuff there too. So the two, as a sports medicine doctor, as you get older, I would say the two areas of injury where I see the most are probably in the hips and in the shoulders. For if any of you have ever studied anatomy, the hips and the shoulders are a ball and socket joint. And around those ball and socket joints, we have a lot of tendons that hook everything together. And over time, these tendons were built as human beings, were built to load those tendons with weight. And unfortunately, as we get older, we tend to sit around more. We tend not to do as much. Maybe we stop lifting weights. And unfortunately, what happens is those tendons tend to atrophy. The blood supply gets a little bit worse. And then over time, you can develop a condition called tendinosis or tendinopathy. Some of you may be more familiar with the term tendinitis, where the tendons tends to start to break down. You can start to develop tears. And by far, for men over 50, the rotator cuff, which is some of the tendons in the shoulder, by far the most common injury that we'll see in our office. So I've been very fortunate to be involved with learning how to do musculoskeletal ultrasound, so we can use an ultrasound machine to help diagnose those here in the office. I have a really cool slide deck that I'd be glad to share with everyone. I'll make sure that gets out too about some preventative exercises that you can do along with this as well. So when we talk about strengthening the rotator cuff, the biggest thing we want to look at is the four muscles that control that. So Those are the supraspinatus, the infraspinatus, teres minor, and subscapularis. So the way that we remember those, I always joke the sports doctors was SITS, S-I-T-S, for us sports doctors who have trouble remembering things. And basically what you can do, if you ever just Google rotator cuff exercises, there's a ton of great content online. One of my favorite rehab people to follow are called the Prehab guys, P-R-E-H-A-B, if you guys are on social media. They have a lot of really great content on there about how to strengthen these tendons. And by far and away, these are the injuries that we'll see the most that definitely can be prevented. The second part of this too is what's called dead butt syndrome, which I have a little bit of this too. And that's is simply what it sounds is, when we sit too much, our gluteal muscles tend to get weak. And when our gluteal muscles are either weak or you have an improper firing pattern, meaning that they're not activating properly, this can develop all kinds of things, all kinds of kinetic chain problems we call. So back pain, hip pain, neck pain, it can all come from weak hip stabilizers and weak gluteal muscles. So I used to serve as a medical director for the Arnold Classic here in Columbus. Dr. Obeng, if you remember, that was one of our big events here. We have weightlifters from all over the world. Some of my favorite T-shirts there were "Never Skip Leg Day" or "Squats and Peanut Butter." There's all kinds of things. So I think, unfortunately, what we do is we tend to overlook our lower extremity exercises. So that's another one usually I'll focus on is how can we load some of the tendons of the hip in a similar way in which we can load the tendons of the shoulder. The glute medius, it's a muscle kind of on the outside of your hip. If you ever sit too much and you kind of have an ache on the outside part of your hip, it's almost certainly that glute medius muscle. And it's an epidemic in America. I mean, I can't tell you how many patients I see over the age of 50 who have weak gluteal muscles who come in with lateral or on the outside hip pain. And then again, with that too, with weak hip muscles, typically this can move to back pain as well. So I didn't want to get too in depth on this. I could talk about these strengthening exercises for hours, but I did just kind of want to touch on the hip and the shoulder and some things that you can do. So many of you have probably been familiar with clamshells and hip bridges and side planks and all of those fun things. So those are all really great exercises that you can get into to help strengthen your hips and help build up your core muscles as well. And so in my practice, so I work with a marathon. I see a lot of runners that come in, and really recently we've been seeing running has really taken off here in Columbus, and I think nationwide too, because it's one of the few things that we can do right now, as many of the gyms are closed. So one of my favorite things to do is I tell patients, if you're new to exercise or you're trying to get back into exercise, or maybe you're continuing it, one of the best things you can do is get fitted for a really good pair of running shoes. So if you can go find a running shoe store, have someone look at the size and type of your feet as well. Many running shoe stores, they have these computer sensors that can look at your arch. They can make sure you're getting the proper size. And it's much better than doing that, buying shoes online, because you can get properly fitted, make sure you're getting enough cushion for your body type and size. And especially if you're trying to get back into running, it's something that often gets overlooked. That's a pretty simple thing that can help prevent mostly lower extremity injuries, things like calf strains and Achilles tendonitis and ankle pain and things like that, especially while running. So that's one of my favorite things to tell patients too, is to make sure before you get back into exercise, really try to get fitted for a really great pair of running shoes there too. So those are some of my favorite things. And again, as we get older, some of the men over 30 or 35 on the call here, I always say, really try to avoid a lot of overhead activity. I know that can tend to kind of beat up some of those tendons there as well. I always say try to keep your elbows at your side there. There's a lot of really great exercises that you can do to build up that strength. And then finally, I did just want to touch on nutrition. I know Dr. Nadolsky will probably talk about this a little bit too. For muscle nutrition, make sure you're getting adequate sources of really good lean protein. We always want to talk about a low-fat, high-fiber diet is really the way to go. And then also, unfortunately, especially up here in Ohio, where we don't get a whole lot of sun, we have to get vitamin D from different sources. So in order for us to be able to absorb calcium to get healthy bones, we have to have vitamin D. Most of the time we get it from the sun. Some other really good sources are things like salmon. I always say try to get the wild caught salmon. That's a great source of vitamin D. Some sardines, which I know sometimes my patients look at me and they're like, I can't eat that stuff. But a lot of the oily fishes are really good for vitamin D. If you don't want to take that as well, there's a lot of great over-the-counter vitamin D supplements you can do as well. And then for calcium, another big source of calcium are leafy greens. So things like kale, spinach, broccoli, asparagus, any kind of those cruciferous vegetables we talk about are really great sources. And Dr. Nadolsky will tell you too, and you can tell I'm a big fan of his because I follow a lot of his content. Eat mostly vegetables and fruits. And you really can't go wrong. A multivitamin doesn't hurt if your diet is not as well balanced, but that can really help with muscle and bone health as well. So I'd be glad to share some of the slide decks and things that I teach our residents and medical students. The biggest thing, if you get nothing else out of today, make sure you're moving on a daily basis. So I know many of us are sedentary. We spend a lot of time sitting in our chairs. Try to get up and move around. I have a kettlebell actually in my office, as well as a pretty large PVC pipe so I can do my shoulder exercises. And I also have some resistance bands. My medical students and residents like to make fun of me. They say that I'm getting old and I can't do this anymore. But, Ben Bring, when I was 20 years old, I could roll out of my bed and play basketball for 5 hours and be fine. But now, unfortunately, I have to do a nice, probably 15 to 20 minute warm up before I even go for a half a mile or a mile jog there. So hopefully that's some good content for you guys. And again, I'd be glad to share some of those slide decks with you. And again, just wanted to say thank you guys for having me. Super honored to be on the call today. So with that, let's roll it to our Instagram star here, Dr. Nadolsky. Looking forward to his presentation here.
Instagram star, I don't know about that, but so I usually what I do on Instagram, and even Facebook, and now apparently just TikTok. Although I don't think I'm going to be a TikTok star. We'll see about that. But I make memes, kind of funny memes that relate to people. So as Dr. Bring was discussing rolling out of bed, one of the funniest memes I was thinking about, I didn't make this one, but my favorite childhood memory was not having back pain. Right. So I want to talk about obesity, and I'm an obesity specialist. That's what I do mostly, but I look at pretty much all chronic disease, or most chronic disease that we see now, preventable chronic disease, through the lens of like too much adiposity. I didn't make any extra slides here. I kind of wanted everybody to put in the chat box, if you can, what is the reason that most people struggle with their weight? If they could just put that in the chat box, I'll kind of get this started here. The first thing I want to talk about is kind of shifting our minds of how we think about obesity. Most people used to think about it like just like a lack of willpower, a sign of gluttony, just like an inert amount of energy that we just store, and it's really frowned upon. It's still frowned upon. There's a lot of what we call weight stigma. I see some good stuff: laziness, overeating, lack of knowledge. This good stuff that I can kind of wrap on. I want to shift everybody's mind, or at least try to get everybody to think of obesity more of like a chronic disease. Now, the first part of this is Dr. Obeng brought up earlier, is that obesity is a risk factor for pretty much all chronic disease. So once you have obesity, specifically abdominal obesity, we can kind of get into the nuance there, but abdominal obesity, the stuff you store around your abdomen as opposed to your legs and hips, which could be potentially protective, but specifically the stuff around our waist, predisposes us to those kind of pre-cardiovascular disease conditions such as hypertension, hyperlipidemia or dyslipidemia, pre-diabetes, type 2 diabetes, and those all lead into cardiovascular disease. Now, some of the other things that we don't think about is, well, having just too much mass around your neck can lead us to things like obstructive sleep apnea. Having too much weight in general goes back to what Dr. Bring was talking about, of like osteoarthritis and pain just in general. So kind of shifting our minds, thinking of obesity as a disease and treating it as such can kind of get people out of the mind of that it's just a lack of willpower necessarily. So this is where it comes into play. Once you have obesity, though, even just having knowledge doesn't necessarily, because I see a bunch of people have put in here kind of a lack of knowledge. So here's kind of some anecdotes for you. A lot of the people that I know and a lot of people around the nation that struggle with obesity, they're the most successful, smartest people that I've ever met, even including physicians. Most people know that, hey, we probably shouldn't eat those French fries and hamburgers, and we should probably get some apples, probably some chicken breast or chicken thighs. I actually like chicken thighs better. I don't actually like chicken breast too much. I like chicken thighs, lean cut, mind you. But most people know that. So like but most people think it's a lack of willpower and a lack of knowledge and things like that. And that's a very common idea. Now, when we actually look in the genetics of obesity, most of the genetic causes are centrally, and it's not, here's another myth. Most people think it's, we have slow metabolisms, right? So unfortunately, this has been dispelled a few times because it'd be nice to blame everything on a slow metabolism. What ends up happening, they studied this, and within like 10% of what we predict using these special calculators, people's metabolisms are just right where they're predicted to be. So the truth is, we do eat too much. And now you may be thinking, well, isn't that because we lack willpower? Well, the thing is, our environments kind of get us to eat too much, combined with our genetics, mind you. So, like, for example, I don't know what everybody does here for work, but I know most of my patients, if they start a diet, they're going to be like, all right, I'm going to be good now. They're going to prep their food. And let's say they go to work and then their friends go, hey, why don't we go order Thai food? Or, hey, I brought donuts in. And you're like, you can say no for the first week. You can say no for the second week and you can try to eat your own food. But eventually over time, due to our environments, we kind of have this slight nudge everywhere we go. You're going, for breakfast. Oh, I don't feel like drinking my protein shake or whatever. I'm just going to stop by McDonald's and get a McMuffin. Yeah, peer pressure. Someone mentioned peer pressure. Um, so for lunch, your coworkers, maybe you. I get like these pharmaceutical reps or sales people in sales. They have to bring clients out. I'm like, well, have you thought about getting salad? It's like, yeah, but then the client wants to get drinks, and everybody's having a few drinks, knocking them back, and I feel like I need to join in to close the deal. It's like, okay, well, okay, you can drink alcohol and lose fat, of course, but all these little things add up. So then you go home and I have a couple kids. In fact, that I had to jump up and get one of them out of here a second ago. she wanted to get on. I mean, I could have let her on, but it probably would have thrown me off a little bit. But so you have a couple kids, they're yelling at you, they want whatever. Your spouse is trying to, she doesn't care, or he or she doesn't care, they're thin and maybe you're struggling with your weight, or vice versa, whatever. Everybody's yelling. So all these little things kind of push you in one direction. So life happens. Combine that with our genetics that have increased appetite with these types of foods that are around us. So I wanted to throw out this idea of thinking of obesity as a disease and not as a lack of willpower per se, but it's all kind of derived from not only our genetics, but our environment. So why in the past 30 years did we all of a sudden have this obesity epidemic? We're not it's not a lack of education. In fact, we know more now. The change is basically in the environment. And the reason this leads to men's health is because, obviously, like I said before, having more abdominal obesity specifically leads to higher blood pressures, worse cholesterol, higher blood sugars. Also leads to hypogonadism, erectile dysfunction, earlier heart disease, and just feeling like crap overall. And so how do we do it? How do we fix this then? How do we prevent all that? Or if we have obesity, how do we fix it? We have to find a way to eat fewer calories than we're burning. So a common myth is that it's our hormones. We got to eat fewer carbs. Well, it doesn't come down to carbs, it comes down to calories. And, things like pizza and burgers and those things, they taste so good, but they're high in both carbohydrates and fat. So as Dr. Bring, I should say, was saying, like, I don't know, finding ways in the morning. How do we find ways for lunch, breakfast, lunch, and dinner to reduce our energy intake while keeping us fuller longer? And it looks different for each person. I wish I could say I have the perfect diet plan for each of you. Um, I'm writing kind of a book about that, but there is no perfect diet, but there are dietary patterns that are conducive to weight loss. And I'll just give you the top stuff. So lean proteins, as Dr. Bring said. I specifically like lean dairy, like Greek yogurt, fat-free Greek yogurt. You can sweeten it by putting a little bit of. You can actually take the sugary yogurt and mix a little bit of that in there. There's some kind of artificially sweetened or low sugar yogurts. So you mix it up and kind of dilute it like that. And there's some other types of sweeteners. So I like lean dairy. Any type of meats that's lean. It could be shrimp, and you may be thinking, well, that's high in cholesterol. The dietary cholesterol doesn't have a major impact on your blood cholesterol compared to like saturated fat. Um, uh, Fish, sirloin, even lean beef. Like I get ground lean beef, it's 93, 95% or 6% or so, ground turkey. Um, and then even protein types of powders. For convenience. So instead of like at lunch, you're like all your friends are like, let's go. You can knock back a protein shake and then go hang out with them if you want, and you won't be as hungry either. That's a good option. I do. So then, what do you eat? What else do you eat? Well, you can't just eat protein all day. Uh, Filling your plate with mostly vegetables. I don't know what kind of vegetables, if anybody wants to put in here what they like, but I like the convenient stuff. Of course, I like the carrots. I like bag salads that are easy to do, just minimal dressing on top and shake it up. Um, Broccoli, anything that's any type of vegetables that's just non-starchy vegetables. That's the stuff that fills you up with very few calories. And then I do think fruits are very good for you. They're very low in calories and very filling, mostly berries and melons. Potatoes aren't bad for you. It's where you fry them, cut them up and fry them, and add ketchup with it and a bunch of salt. Those are easily overeaten. So if you eat more like boiled potatoes, that's fine. Lentils are very good. Asparagus, somebody said. And then fat's not bad for you necessarily either, but I would get the more healthful fats like nuts, avocados, olive oil. So that's the kind of thing, so if I'm giving you a meal plan in the morning, what I do, again, you don't have to do this, but you could have a ready to drink protein shake. You can add it to your coffee, like sweet, almost like a creamer. So that's why I use the Premier protein shakes and add it with coffee. And then have an apple, a couple apples on the way if you're trying to go to work quickly. That way you get your coffee and all your meal in. And then for lunch, yeah, it's usually the easiest thing is having leftovers from the night before. But a good easy meal would be frying up a bunch of ground beef or heating up a bunch of ground beef, turkey, having it with a little cup of like brown rice, or it doesn't have to be brown rice. It could be white rice too. It doesn't truly matter. And then having a ton of vegetables with it. Where we get into trouble is where we start frying things and adding all that fat and carbohydrate type of food together. Those are just the most easily overeaten stuff. So lots of different meal ideas. I just, the things I wanted to cover mostly is the thinking about obesity as a disease, understanding it's not just willpower and lack of knowledge, that we're driven to eat these types of foods that we're surrounded by, but you can fight back. It's not just hopeless. It's just that it goes above and beyond knowing, because a lot of us know, yeah, probably shouldn't eating those French fries or whatever it is. We know that, but finding ways to make it convenient and more simple for you. Someone asks, is eating breakfast crucial? It really, what turns out it really isn't. The total daily energy intake is what matters the most. So if you skip breakfast, it just shifts how much you can eat during the rest of the day. And so that's why some people think this kind of time restricted feeding or intermittent fasting type of meals can be fine. Now, the thing is, what people do is they skip breakfast and then they're hungry and then they eat a bunch of crap at lunch and then dinner because of that. But if you purposely do it and you schedule things out, it can be a fine way of cutting out calories or energy intake. So on the other hand, some people who skip breakfast and then you give them breakfast, that may temper them at lunch to where they're not going crazy so much. So nuts, avocado oil, yeah, very good. Cassava flour, oh, it just depends. I mean, it all comes down to energy balance. I don't personally use the cassava flour. I've used like lentil flours and things like that. It can give a lot of people gas and whatever, but I do like lentils and beans are very good. Very filling, high fiber, low calorie. Kale, sweet potatoes, yep, all that type of stuff is good. Yeah, that's kind of all I wanted to bring up. Is in the lens of men's health, very important for testosterone. Guys will come in with hypogonadism. They're like, my testosterone's low, and I'm like, okay, well, we got to figure out the cause. You don't just want to, just start shooting them up. As the Dr. Obeng was saying, you got to look for, the cause of these things. So a lot of times obesity is the cause, and you get them to lose weight, testosterone may not skyrocket to like 1,000, but it can go up from like the low 200s to the 400s, 500s, and be normal. So yeah, I think that's all I wanted to say, really.
All right. Thank you so much, Dr. Nadolsky. Thank you so much, Dr. Bring. Thank you so much, Dr. Obeng. This has been so excellent. I am now going to go ahead and start with some of the questions that have been asked in the chat, and we'll just kind of open this up for a Q&A session. So I'm going to start with the question that was asked earlier. And the question was, how confident are we that PSA only is an effective measure for early detection? I believe the medical community has not too long ago moved in this direction. Dr. Obeng or any of our panelists want to take a shot at that one?
Yeah, I'll talk a little bit about that. It isn't. So what the PSA is one of many tools. So it's in the past, it was one of the main go-tos, but now what they recommend is it's more of a doctor-patient decision whether or not to do a PSA on a patient, and you also have to look at the risk factors too. Typically, if the gentleman is older, usually there's like around 75 or older, we usually don't do a PSA. It's not really recommended by the guidelines, and if the patient is not symptomatic, if they're younger than symptomatic, it's one of those things that you have to talk to the patient about whether or not they want to check that or not, because it has a kind of a risk versus benefit thing. Like if you see an artificially elevated PSA, is the benefit of further investigation, whether it be biopsies and stuff like that, is it worth it? So right now it's not. It's one of those things that at the current moment it's one of the tools you can use, and it's one of the tools that we use, especially in primary care. But it's not the only tool, and it's one of those things that you have to kind of talk to the patient about. If this is something that you as a doctor and the patient agree this would be a good test to do, that would be something that could be beneficial. So
Excellent. Thank you so much, Dr. Obeng. Another question that was asked in the chat, which is a question on all of our minds: why does fried food taste so good?
Yeah, I mean, it's a great question. Like probably the best answer is that we're kind of designed to want to eat like higher calorie types of foods. It might be an evolutionary thing, but the basics are like, you take like bread by itself or breadcrumbs by itself, it's like, nah, those taste okay, right? You take oil by itself and it's like, nah, it's all right. You take salt by itself, it's like, when you combine it all, it hits all these different receptors, and it lights up parts of our brains that make us go, ooh, that was good. We want some more of that. And so that's why you see some of these studies where they look at the differences of palatability, they call it, and for some reason these hyper palatable, ultra processed foods don't even register satiety in ourselves compared to the more whole, not so calorie dense types of foods. So why? It's probably an evolutionary thing, but it doesn't take a neurobiologist to say like, hey, we should probably step away from these things because we are just so driven to eat them. I am too. I mean, people are like, oh, you have, why do you have so much willpower? Like, no, I like them, It's just that, again, that goes into the kind of the struggles of obesity. Uh, Growing up, taste changes, cultural changes and differences. But yeah, I wish I had a pill. There are some new medications that do tamper our drive to eat more, but yeah, I guess that's for another discussion.
I was going to go right ahead and move this to the open Q&A session and actually allow people to just ask questions directly into the forum. So if you have a question, I would love for you guys to just unmute yourself and go ahead and ask your questions. Let's make this as interactive as possible.
Well, actually, I'll start that off then, Dr. Segundro. Okay, so I myself, due to military service, have a lot of injuries and whatnot and mobility issues, such as an FAI, which femoral acetibular impingement. So I can't really do a lot of the strength workouts that I used to do, such as deep squats and things like that, to maintain like glute strength, ham strength, things like that. So is there something else, such as maybe ergonomics, that could hit that same sort of strength maintenance? So it's like ergonomic rowing.
Dr. Bring, I think that might be all you.
Oh yeah, absolutely. So, whenever I have a patient, unfortunately, as we get older, we have injuries, especially FAI is a tough injury, because probably you also probably have a labral tear. For those that know the anatomy, there's a labrum that kind of helps hold the joint together. It can be very uncomfortable, it can be very painful. And so the key here is modification. So I always tell my patients, we can always figure out a way to help you exercise. And you're right, like, so that deep hip flexion, maybe if you ever did like, front squats, back squats, overhead squats, and that's okay. And those days may be behind you. And, there are other ways of kind of moving forward with this too. There's a lot of really great things you can do. One of my favorite things to do is just work on even shallow squats. So if you put some books on a chair, and obviously you're not going to get that deep hip flexion, but even just getting the quadriceps, the hamstrings, there's a lot of really great machines that you can do to help strengthen those muscles individually as well. I'm a big believer in whole body strengthening. So if you can get into things like yoga, Pilates, even I know some of the bar classes too, some of those things are a little bit less like heavy weightlifting and a lot more core stability and a lot more overall just body posture stability exercises that can be very, very beneficial for you. So I'm all about modification. So full disclosure, when I don't bench, I had a really bad shoulder injury a couple years ago. So when I bench press, I only do incline, and I don't actually go all the way down to your sternum, because that that pinches my shoulder. So I'll have a towel rolled up and I'll do just like a towel bench. And I don't lift heavy weights anymore. There's still really good data out there for light weightlifting, for, lower weight, high repetition. So what I did to trick my neighbors when they walked by is I bought 10-pound bumper plates that look like they're 45 pounds. So on my, so on my bench press, it looks like I'm repping out at 135 pounds, but really it's only 65 pounds. But for me, I'm all about the low weight, high rep stuff, and just staying as active as you can. When I hit 34, I had a ton of injuries. And so for me, it's just been about how can I modify? So for example, I have a big ganglion cyst in my wrist, so I can't do push-ups on my hands. So I have to do push-ups on dumbbells now, and that's the only way that I can do them. So I'm all about modification. We live in such a great technological age now. There are so many great people on social media and on YouTube that can help you, kind of custom tailor and figure out ways to modify. FAI that's a tough injury though, and those hurt. As a non-surgeon, I always tell patients I try to do everything I can to help prevent surgery. So a young man like yourself, I would say, go out there and see if you can find a good sports medicine physician or physical therapist or somebody that can help you meet your goals. Recently this year, I've just gotten into medical acupuncture. It's really totally changed the way I look at how I treat patients for everything. I almost feel like I was blind all these years for all the ways of doing different ways of treating patients there too. So we're always looking for ways to help treat patients non-operatively. FAI is one injury, though. If you do have a labral tear, it depends what kind of deformity you have, a pincer deformity versus a cam deformity. Those are one that actually does really well with hip surgery. So that's one that I usually say, labral tears, they don't do as well as we get older. But if you have true cam or pincer deformity, that's one that the data is pretty good for surgical intervention there. So sorry for that long-winded answer. Dr. Sagunra knows I was ready for that one. Yeah.
Thank you so much, Dr. Bring. That was awesome. We have a question. Is it good to eat white bread or whole wheat bread?
Glycemic wise, I'll just answer this. Glycemic wise, meaning the response of blood sugar to what you eat. There's probably an effect of eating wheat bread over white bread. But you'd have to look specifically at the types. There's a lot better like whole grain types of bread that have a lot more fiber, whereas other ones, it's basically like they food color white bread to make it look a little bit browner. So you have to really look at the labels. But in terms of like losing weight, really it comes down to how many calories you eat. So if the whole grain bread fills you up a little bit more, despite the same amount of calories, that would be the better choice. But if you just wanted to eat it for taste wise and you account for it in other places in your diet, it's fine.
Dr. Bring says, watch for added sugar in the bread too. So absolutely, thank you. Dr. Obeng, question for you. In terms of, our cardiovascular risk and our diabetes risk, a lot of patients fall in several different categories of comorbidities. And really, when we talk about health disparities in certain populations, that's a really big thing. Can you just maybe speak on a couple things that you tell your patients, right, that are maybe pre-hypertensive, pre-diabetic? What are some preventative measures that you tell them in your office and say, hey, before we get you on medications, let's try these 2 or 3 things? Can you tell us a couple things, and maybe some people in the audience can take some information from that?
Sure. Thank you, Dr. Sagunra. I appreciate it. It kind of goes along with the lines of what Dr. Nadolsky was saying, Dr. Bring was saying, lifestyle change. So typically what I'll recommend is that they get exercise in at least 3 times a week and at least 30 minutes of good cardiovascular exercise in. Ideally, I like them 5 days a week, but I say a minimum 3, but 5 days a week, 30 minutes at a time of cardiovascular exercise in. And then also watching their diet as well, like Dr. Nadolsky was saying, the types of foods they eat, their calorie intake, trying to eat the right types of foods as well, and then watch their portion sizes, of course. It kind of goes along with eating less calories. So those are kind of things I tell them. And then, of course, getting proper rest as well. Those are some of the things, and eating, drinking plenty of water. Those are kind of things I kind of talk to them about, especially my people who are borderline, who might have that A1C and the A1C basically is a blood test to look for diabetes. So if they're borderline, where it looks like they're in that pre-diabetic range, like you were saying, Dr. Sagunra, then I'll say, okay, do these types of things. I recommend you do these first before I put you on like a metformin or put you on blood pressure medication. Like even cardiovascular exercise itself can help to lower your blood pressure at least 5 to 10 millimeters of mercury just on that alone, and that's great. And patients feel good when they do that, when they kind of engage in those lifestyle changes. So those are the kind of things I advise them to do.
Excellent. Thank you so much. There's another question. Is there a way to jumpstart the body's testosterone production? I'm going to leave this to the men.
In terms of like, if you have, it really comes down to what's the underlying cause of your testosterone. So like if your testosterone is normal, the normal range can be anywhere from the mid lower 300s up to like 1100 or so. So like, what would be the purpose of increasing it? If you're having symptoms, for sure. If you don't have symptoms, a lot of people will just check it, and maybe they checked it wrong. A lot of people, you really got to check at 8 a.m. fasting when you do it. But the most common thing I see is just excess abdominal weight. And so if you can somehow reduce 5-10% of your weight, especially abdomen, that would be the best way to boost it. But in terms of supplements, there's no good supplements to do it.
Yeah, I agree with Dr. Nadolsky. There's really no supplements that necessarily would naturally boost your testosterone. It's more of a getting to the root cause of it to kind of get your numbers correct, to get your numbers up. So
Excellent.
I'll chip in one more thing if that's okay too. So just be careful. There's a lot of low T clinics. I know I hear the radio ads around, and we see a lot of inappropriate prescribing of testosterone in the medical community. So just make sure you're seeing someone who's has experience with testosterone replacement if you meet criteria for it. I know I have a lot of patients who, like Dr. Nadolsky mentioned, some of the ranges that come in with, testosterone levels in like 1,500 to 2,000 range. And as Dr. Obeng had touched on earlier, there are a lot of risk factors that come along with exogenous testosterone or testosterone that doesn't come from your body. So I always say just be very careful. If you do, you'll hear these ads like, oh, do you feel tired you're over 40? So anyway, yeah, just be careful and make sure you're asking good questions there for the one who's prescribing that.
Yeah, I'm sorry. I totally agree with you, Dr. Bring. So actually, I worked in kind of something similar. So where I used to work at, that was one of the things. But one of the things that I had an issue with, and that's part of the reason why I left, was the fact that we weren't doing two readings. Ideally, you want to get two separate readings, two different days. And like Dr. Nadolsky was saying, fasting readings in the morning, first thing in the morning, because what can happen is your testosterone tends to be at its highest in the morning. So if you're checking somebody, they come into the office like 2 p.m, the numbers are going to be reading low, but that's expected. So you can't say, oh, you have low T. We didn't check you at the right time of day. So I totally agree with that. So.
And did I hear you earlier say that it also has a link to your prostate as well? So you don't want too much testosterone because it can impact your prostate. Did I hear that, or did I make that up?
That's correct. That's correct. With the prostate, a lot of times when you're looking at the prostate, it feeds off of testosterone. Now, when it comes to, and the jury's out, and there's a little bit of controversy over whether or not testosterone therapy can cause prostate cancer. It can definitely cause your PSA to go up. But in the urology community, they're saying there might be a saturation point where someone who might have had prostate cancer or something like that, if they were on therapy, or if they've been treated for prostate cancer and they start testosterone therapy, shouldn't be an issue. But it is one of the things that we monitor, I would say. So whenever someone's on testosterone, you want to monitor the PSA because it can tend to go up, and that's something you want to be careful of. So I always tell that to all my patients too. If they're on testosterone therapy, make sure whoever's prescribing is monitoring your PSA. You just want to be careful with that.
Excellent answers, doctors. Thank you so much.
I have a question regarding a different topic, but I'll wait. I'll let you go through what you need to go through.
Yeah, I was just going to ask, there's a question here for thoughts on the COVID-19 disease and or vaccination in regard to the long-term potential and ramifications. This is a question that can probably be like a whole nother hour conversation. So I was wondering maybe Dr. Obeng or Dr. Bring just kind of, or Dr. Nadolsky, any one of you maybe want to just take a quick one-shot answer at this for the vaccine.
I would love to. I love talking about the vaccine. I would say I think this is the greatest accomplishment, one of the greatest accomplishments in human history. The fact that we were able to sequence this virus so quickly and get the vaccine out. These vaccines will be the most studied vaccines in human history as well. The clinical data so far, obviously, as many of you have probably seen with Moderna and Pfizer, is outstanding. The safety profiles are outstanding. I do want to just put in a plug. These mRNA, I always say it's kind of like a cheat code. In no ways are these vaccines changing or altering any DNA. I know there's some things some really bad information on the internet out there. And so the mRNA is just a very, very tiny piece of protein that tells our body to respond to the virus when we see it. And so it's amazing the technology that's been developed behind this. I won't get into the clinical data for AstraZeneca or Johnson & Johnson. But I will say I've had the vaccine. My family members have had it. I recommend it for all my patients. And the clinical data is fantastic. So I don't know if the others have thoughts on that too, but I would highly recommend it.
Yeah, I agree with Dr. Bring on that one too. I got mine as well. I highly recommend getting the vaccine. It is definitely something that was a great feat of science, because it's just so cool how the technology works in terms of how it helps build immunity. So I definitely encourage people to get it.
I'll third that.
Excellent. I just have to jump in real quick on this one. All I ever tell people who have doubts and who have questions, it's normal to have questions, right? It's normal. But we need to remember to trust science. And one thing that I can tell you from my personal experience working in the COVID units and having patients die every day, what we may not know about the vaccine, okay, is nowhere near what I do know about COVID, okay? And I know that COVID kills. COVID does not take any prisoners, and COVID doesn't care who you are or where you're from. So I'll put that plug in. I've also been vaccinated. I recommend everybody be vaccinated when you're able to. All right. I think, Mr. Freeman, you were starting to ask a
Yeah.
question. I'll let you go ahead and ask that.
So, and I'm hoping I say this right, but so, for the last 20 years or so, at least since my early 40s, I've been getting the annual exams. But as I get older, I really wonder if, my primary care physician is running all of the tests and all of the things that they should be doing especially as I get older. Because when I get my exams, I often have to push to do a complete blood test, to do a urine test, and all of those things. And maybe part of it is just being paranoid because as you get older, you think things are happening with your body. But are there is there a standardized recommended set of things that you should be looking for? Or are there some things, especially as Black males, that we should be looking for when we go to do our annual exams? And because I know sometimes the primary care physicians are driven by what the insurance will pay, I think. Maybe I'm wrong. But I just want to make sure that I'm not that guy 10 years down the road saying, I wish I had that test taken. And I wish I'd pushed more for that exam. Does that make sense?
Yeah, that's a great question. I would say the first place to look is what's called the USPSTF, and I'm glad to type that in the chat box. So it's United States Preventative Task Force. And what you can do, you can even go online, type in your demographics. You can say, this is my age. I'm a 38 or 40-year-old man with this blood pressure, and it will actually show you all of the different screenings. They have a really cool app that you can do. And a lot of times when I do physicals with my patients, I'll pull up the app on my phone and we'll kind of go through it together. So you can see what's recommended for your age as far as like preventative screening.
Thank you.
Excellent. And our last question that we had here for the night is, or we have a couple. One is from a patient who wanted to know, if you have a meniscus tear, is it necessary to have it repaired? He has limited mobility on that leg.
All right. So I guess hopefully I'll get to jump at this one too. So this is one of my favorite clinical questions. So a couple of years ago, there was a study published where they did 3 groups. They did a control group, which was a non-surgical group. They had where they only did PT, and then there was a surgical group that actually got their meniscus repaired, and then a surgical group that had a sham surgery. So basically, and don't ask me who would sign up for the sham surgery, but I'm pretty sure it was a double-blinded, meaning both sides didn't know. The long-term results showed, so I think this was for patients, I'd have to look back, but it was age 40 to 65, I believe. Because unfortunately, as you get older with arthritis, almost everyone has meniscus tears. And the group that did physical therapy actually had better long-term pain scores than the surgical groups did. So now I will say this is with a caveat too. If you have a large, what we call a bucket handle tear, where you have a huge tear in that meniscus and you have mechanical symptoms, so you can't straighten your leg, you get a lot of catching or locking, sometimes those need to be repaired. But as someone who's a non-surgical sports medicine person, I'm always looking for ways to rehab out of those injuries. The unfortunate thing is with meniscus tears, we don't have great blood supply to that part of the knee, and so sometimes as we get older, it can be a little bit harder to heal. But I would definitely look at doing physical therapy and pursuing the non-operative ways too. Unfortunately, once we cut that meniscus out, that's it. It doesn't grow back. That's kind of like right now, I always tell all of our students, so if any of you are on the call or in science fields, the holy grail of medicine and sports medicine right now is, being able to regrow cartilage. That's like, you'll hear all these things about PRP, stem cells. If we can somehow figure out a safe way to regrow and repair cartilage without having to do total joints, that's going to be the future of sports medicine and arthritis there. So I hope that helps. I know it can be, meniscus tears can be very, very frustrating, because you can't do the activities you want to do. So that's really where have a great discussion with your doctor, kind of look at what are you able to do and what would you like to do, and see kind of like what your limitations are. Unfortunately, just as you go on, those knee scopes can take a toll on you and put you at higher risk for early arthritis down the road.
Excellent. Thank you so much. Thank you so much, Dr. Bring, Dr. Obeng, Dr. Nadolsky. You guys are not just my friends, you're my colleagues. I appreciate you so much for coming tonight and giving us wonderful information that has been so helpful to everyone in the audience. I put in contact information for Dr. Nadolsky in there, as he is, our social media doctor who lifts. He's Insta famous and we're privileged to know him. I gotta tease you, make you blush a little bit, Spence. And I would actually like to give a couple minutes to Mr. Kager to give a couple closing words and thank us for having the Omicron fraternity chapter join us tonight. We've been very, very lucky and we've had a great discussion. So, Mr. Kager.
All right. Thank you, Dr. Secundro. I think he does lift. I did kind of see some of that bicep look over there. So I think he does actually. I'd like to thank Michael Basley, our International Director of Social Action, for stopping in, and Reginald Slush, our International Director of Bigger and Better Business, for stopping in as well, and our chapter president, Cameron Shaw, who's in there. Thank you guys for coming out and everybody. And like I mentioned, I have a lot of injuries. All three of these specific panels, panelists have hit on a lot of things that deal with me. I have my resistance bands right here. I do some online streaming, so I sit down a lot, and I'm out there just getting it as well in the middle of it. So I feel like this is something very important. Now, we didn't touch on this question, but I think the sweet potato needs to be addressed as far as glycemic, as an alternative for good, healthy eating, the sweet potato. So, but thank you very much, Dr. Secundro. Appreciate it.
Thank you so much, Mr. Kager. Also on here, Mr. Ira Hughes from your chapter, who I've been communicating with regularly, who was really integral into helping us kind of get your chapter involved. Thank you so much, Mr. Hughes, as well. Again, I'm just going to go by everyone's first name because we're friends. Spencer, Ben, Pa, it has been a pleasure. I thank you guys so much for joining me today, for volunteering your time. You guys are awesome, and I'm proud and honored to call you guys colleagues and friends. And if anyone has any last-minute questions, we can maybe entertain one. If not, we will call it tonight.
Great panel discussion, guys. Thank you very much for working with us on this, okay?
Thank you so much. Thank you. Again, thank you so much to our panelists. Thank you to our Omicron chapter of the Phi Sigma fraternity. And we've just been so grateful to have you guys with us today. And, hopefully we'll do some more stuff in the future. And again, to our panelists, I thank you so much. Everyone have a great night. This will be recorded, or has been recorded, and I will make sure that you have access to the video. Please feel free to communicate with me via the doinfluence.com, our online platform for educating, empowering, and influencing the next generation. So I'd love to hear from you guys. You can follow us on social media, and yeah, we'll call it a night. Thank you so much. Everyone have a blessed evening.
You too, Doctor. Good night.
Thank you, guys.